Okay, so let's unpack this. Today we're diving into, one of the most fundamental areas of pharmacology.
Absolutely. We are talking about the drugs that basically wage chemical warfare against the body's own fight-or-flight system.
Right, the antiadrenergic agents, the molecules designed to counter adrenaline or, epinephrine and norepinephrine.
This is truly foundational stuff. Our listener wants a clear, thorough map of these agents, and we're focusing on the big ones, the alpha and beta blockers.
And the scope here is just huge. 1 minute you're controlling a hypertensive crisis, the next you're managing something chronic like heart failure.
Or even just reducing eye pressure and glaucoma. It's an incredibly diverse class of drugs.
So the mission then is to really get how they achieve such broad control. And fundamentally, we're talking about competitive antagonists.
Precisely. The whole concept is competition. Think of a cell receptor as a lock.
Okay.
And the body's own messengers, adrenaline, norepinephrine, they're the keys. These drugs, these antiadrenergic drugs, are like fake keys.
They fit in the lock but don't turn it. They just jam it up.
Exactly. They jam it so the real key can't get in and activate the cell. They are blocking the effect right there at the effector cell itself.
And this is where we hit that first really crucial distinction. It's a major aha moment.
It is.
We have to separate these receptor blockers, the true antiadrenergic drugs like, say, propranolol, from this other kind of older class.
The adrenergic neuron blocking drugs.
Yeah.
It's a completely different mechanism, a different philosophy almost.
So if the receptor blockers are jamming the lock on the cell door, what are the neuron blockers doing?
There's a supply chain problem. Agents like reserpine or guanethidine, they don't touch the lock at all. They interfere with the supply chain. They disrupt the storage or maybe the release of the transmitter from the nerve ending itself.
So let's play this out. If a clinician gives a shot of adrenaline to a patient who's on one of these neuron blockers, what happens?
Well, the injected adrenaline completely bypasses that whole nerve terminal, that whole supply chain problem. It goes straight to the receptor.
And the receptor is wide open.
Wide open. So the adrenaline works perfectly, maybe even more potently, because the body's own system is depleted. That is the litmus test.
Fascinating. So if I inject adrenaline into someone on a receptor blocker, the effect is blocked. But on a neuron blocker, the effect is, if anything, stronger.
That is the fundamental difference.
Okay.
And it tells you exactly where the drug is working. Is it at the neuron or is it at the organ?
So let's start with the latter then, the antiadrenergic receptor blockers.
Let's do it.
All right, let's start with the alpha blockers. When we talk alpha receptors, we're really talking about controlling smooth muscle tone, right?
We are, especially in the vasculature. So these agents are, our primary tools for messing with peripheral resistance and blood flow.
Their main function then is pretty straightforward. They inhibit responses that are mediated through alpha receptors, mostly alpha-1 and alpha-2.
And the clinical impact is most obvious because of those alpha-1 receptors on the blood vessels.
Right, because alpha-1 activation means intense vasoconstriction, which jacks up blood pressure. So blocking them should do the opposite.
It should, and it does. Blocking them reduces peripheral resistance, which is the main driver of the blood pressure drop. But there's a really important secondary effect.
Okay.
The action on the capacitance vessels, the veins.
Ah, the veins also have alpha-1 receptors.
They do. And blocking them causes blood to just sort of pool in the periphery.
Yeah.
In your legs, in your abdomen.
So if blood is pooling out there, less of it's coming back to the heart. That's reduced venous return.
Which immediately leads to reduced cardiac output. And that contributes even more to the fall in blood pressure. So you're hitting BP from two angles, lower resistance and lower cardiac output.
That sounds really effective, but I can already see the problem. It creates this very predictable issue with gravity, doesn't it?
The problem of posture, orthostatic hypotension. When you stand up, your body relies on this incredibly fast reflex constriction of your vessels to push blood up to your brain.
And alpha blockers just cripple that reflex.
They absolutely cripple it. The pooling effect becomes dramatic. The blood pressure plummets when you stand, and that leads to dizziness, feeling lightheaded, or even fainting. Syncope.
So that's the #1 side effect that patients complain about.
It's the most common and often the thing that makes people stop taking the drug.
Now, to really understand just how dominant these alpha receptors are, we have to talk about this amazing old experiment, the vasomotor reversal of Dale.
It's foundational. Sir Henry Hallett Dale, 1913. It's a beautiful demonstration. Normally, if you inject a big dose of adrenaline, it hits both alpha and beta-2 receptors.
Okay, and the alpha effect is vasoconstriction, which is much stronger than the beta-2 vasodilation.
Exactly. The powerful alpha constriction just completely overwhelms the moderate beta-2 dilation. The net effect is always a big rise in blood pressure.
So what Dale did was he gave an alpha blocker first.
He disarmed the alpha system. He blocked all those vasoconstrictive sites. Now, when he injects the adrenaline, its pressor action, the thing that raises blood pressure, is completely gone.
So all that's left is the adrenaline hitting the beta-2 receptors.
The unopposed action on beta-2, which is vasodilation.
So the adrenaline, which normally raises blood pressure, now only causes a fall in blood pressure.
It's literally reversed. From hypertensive to hypotensive, it's just a stunning, clear proof of how dominant that alpha vasoconstrictive tone really is.
And besides these big hemodynamic shifts, patients notice other things pretty quickly because these alpha receptors are all over the place.
They really are. Blockade in the nasal blood vessels. You get annoying nasal stuffiness.
Right.
In the eye, you block the radial muscles of the iris, and the pupil constricts. That's meiosis.
Yeah, and what about the gut?
Well, sympathetic tone normally relaxes the gut. So when you block that with an alpha blocker, intestinal motility speeds up. Some patients get loose motion.
And of course, the body's master compensator, the kidneys, they have to get involved.
Oh, they always do. When the blood pressure drops, the kidneys sense it as a volume problem. So renal blood flow goes down, and the body starts retaining sodium and water to try and push the volume back up.
But it gets worse, right? Because there's a reflex release of renin.
A powerful one. And the release of renin is actually mediated by beta-1 receptors.
So the alpha blocker drops the pressure, and the body's reflex response is to fire up the beta system to counteract it.
Exactly. The beta-1 receptors in the kidney release renin, which kicks off that whole fluid retention cascade. It is a classic textbook example of drug-induced homeostatic counterregulation.
Okay, so to really get the power of these drugs, we need to look at the chemistry. We have the simple competitive block, the equilibrium type, and then something much more aggressive.
The non-equilibrium type. Let's start there with phenoxybenzamine. This isn't a polite competition for the receptor. This is molecular destruction.
Chemical aggression. How does it get to be so irreversible?
Well, phenoxybenzamine is a halogenated alkylamine. In the body, it forms this highly reactive intermediate, an ethyleniminium ion. And this ion is so aggressive, it forms a permanent, strong covalent bond with the alpha adrenoceptor.
A covalent bond, so it's literally fused to the receptor. The lock is permanently broken.
That's why we call it irreversible. The drug's effect doesn't stop when the drug is gone from your system. It lasts for 3 or 4 days until the cell can physically build brand new receptors.
It's a total system reset.
It is, and that translates clinically to a very steady, reliable block. The drop in blood pressure is mostly postural, and the venodilation, that blood pooling, is actually more prominent than the arteriolar dilation.
And it gets into the brain.
Oh, yes. It's highly lipid-soluble, crosses the blood-brain barrier easily. A rapid IV dose can cause CNS stimulation, but taking it orally long-term usually leads to more, depression, lethargy, feeling tired.
So with that kind of profile, where do you even use it?
It's almost exclusively for very specific situations. The main one is managing pheochromocytoma.
The tumor that pumps out massive amounts of catecholamines.
Exactly. You need that powerful, continuous block to stabilize the patient before they can go to surgery.
Okay, now let's pivot to the equilibrium type. Phentolamine. This is the more classic reversible blocker.
Right. Phentolamine is fast-acting, short-acting, we're talking minutes, and it's easily reversible. The big drawback, though, is that it's non-selective. It blocks both alpha-1 and alpha-2.
And we know blocking alpha-2 has a big consequence.
A huge one. Alpha-2 is the presynaptic brake. It's the feedback loop that tells the nerve to stop releasing so much norepinephrine.
So if you block that brake,
you get a massive surge of norepinephrine release. All that extra norepinephrine then floods over and hits the beta receptors on the heart, causing a really marked reflex tachycardia, a racing heartbeat.
Which really limits its use for, say, chronic hypertension.
Absolutely. So it's used for diagnosis and short-term management of pheochromocytoma,
where
you want that fast-on, fast-off action.
And for emergencies.
Yes, that's a common one. If an IV line with norepinephrine or dopamine leaks into the surrounding tissue, it can cause severe vasoconstriction and tissue death. You can inject phentolamine locally to counteract that. It's a rapid rescue antidote.
So given the problems with both of those, the severe hypotension from one, the tachycardia from the other, the development of the highly selective alpha-1 blockers must have been a game changer.
Oh, a massive leap forward. Prazosin is the prototype here.
And it gave us the best of both worlds, really. The selectivity is incredible, isn't it?
The alpha-1 to alpha-2 selectivity ratio is something like 1,000 to 1.
1,000 to 1, so it just completely leaves that alpha-2 presynaptic brake alone.
Untouched, which means you avoid that big surge of norepinephrine, and so the reflex tachycardia is very mild, or it doesn't happen at all. A huge improvement in how well patients tolerate it.
So it still lowers blood pressure by reducing peripheral resistance, but it's more manageable.
It is. It tends to dilate arterioles a bit more than veins, which also helps mitigate that severe postural hypotension.
But it's not totally gone, is it? This is where the famous dose effect comes in.
That phenomenon is very real. The first few doses can still cause a pretty significant drop in blood pressure when you stand up, making you dizzy, maybe even faint.
So the advice to patients is critical here.
Non-negotiable. You start with a very low dose, and you take it right at bedtime. That way you sleep through the peak effect and minimize the risk of falling. Most people, fortunately, get used to it after a few weeks.
And there's a hint in the source material that prazosin is doing more than just blocking receptors.
Yes. It also inhibits an enzyme called phosphodiesterase.
Okay.
And that enzyme normally breaks down an intracellular messenger, CMP. So by inhibiting the enzyme, you get more CAMP in the smooth muscle cells, which contributes to even more vasodilation. It's like a 2-for-1 deal.
Now let's pivot to where these drugs have just completely changed the game. Benign hypertrophy of the prostate, BHP.
Right. And here we have to think about static versus dynamic obstruction.
The static part is just the prostate getting physically bigger and squeezing the urethra.
Correct. But the dynamic part is the smooth muscle tone. In the bladder trigone, the sphincter, the prostate itself, that muscle tone is heavily regulated by alpha-1 receptors, specifically the alpha-1A subtype.
So that muscle tone is creating this extra unnecessary resistance.
It is. So by blocking those alpha-1A receptors, you just relax the plumbing.
And urine flows more freely.
Exactly. It's a rapid, significant improvement in symptoms. The frequency, waking up at night, not feeling empty. It's why these are often the first-line treatment.
So which drugs show that evolution toward being really prostate-focused?
Well, first you got longer-acting agents like terazosin and doxazosin. They let you do once-daily dosing, and they work for both hypertension and BHP.
But there's a fascinating side note on those two, isn't there?
There is. Some data suggests that they might actually promote apoptosis, that's programmed cell death, in the prostate cells.
So wait, they might not just be treating the symptoms of the enlargement, but actually slowing down the enlargement itself?
It's possible. It's still being studied, but
Okay.
it points to these drugs having more complex effects than we first thought.
And then the drugs got even more targeted, more uroselective.
Right. You have elfusocin, which was designed just for BHP. But the real game changer was tamsulosin. It is highly selective for the alpha-1A and alpha-1D subtypes.
Which are the ones concentrated in the prostate and bladder neck.
Exactly. So it hits the prostate hard, but it leaves the blood vessels where you find more alpha-1B receptors, mostly alone.
So you get all the urinary relief with almost no impact on blood pressure.
Minimal impact on blood pressure or heart rate. You avoid the postural hypotension risk, which is fantastic for older patients.
But that super selectivity comes with its own unique side effects.
Two big ones. First, a fairly high rate of retrograde ejaculation, where semen goes backward into the bladder instead of forward.
And the second one is a big deal for surgeons.
A very big deal. Intraoperative floppy iris syndrome, or IFAS. The alpha-1A blockade makes the iris muscle floppy, so during cataract surgery it can billow and collapse, which makes the procedure much, much harder.
And the newest agent, silodosin, takes that selectivity even further.
It does. It's even more alpha-1A selective. Fantastic for urine flow, basically no change in blood pressure. The trade-off, that failure of ejaculation becomes even more frequent. It's a real issue for a lot of patients.
And just to round out the alpha blockers, we have this one oddball, yohimbine.
Yeah, yohimbine is a natural product from a West African plant. It's a relatively selective alpha-2 blocker.
So it does the opposite of what we've been talking about. It lifts the presynaptic brake.
It does. It increases norepinephrine release, which raises heart rate and blood pressure, creates a state of excitement. It's been marketed for years as an aphrodisiac, but there's really no good clinical evidence for it, no valid use in modern medicine. Okay, so now we pivot to the beta receptors. This is the primary target for so much of cardiology. And the introduction of the first big success here, propranolol, back in 1963, was just revolutionary.
Propranolol is the classic first-generation agent. It's non-selective, right? It blocks both beta-1 in the heart and beta-2 elsewhere, like the lungs and blood vessels.
That's right. And its cardiac actions are the main event. Beta-1 receptors are what mediate sympathetic stimulation of the heart.
So by blocking them, propranolol just calms everything down.
It puts the heart on cruise control, it decreases the heart rate, it reduces the force of contraction, and that dramatically lowers the heart's workload and its oxygen consumption.
Which is why it's so good for angina.
Exactly.
Yeah.
And it also dampens the heart's electrical system. It decreases automaticity, slows down signals through the AV node.
But the way it lowers blood pressure is actually pretty complex. It doesn't cause an immediate drop, does it?
No, and that's a key paradox.
Yeah.
Acutely, when you give it, you definitely reduce cardiac output. But because it's non-selective, it's also blocking the beta-2 receptors in the blood vessels.
Which normally cause vasodilation.
So you block that, and the total peripheral resistance, the TPR, actually goes up a little bit, or at least stays the same.
Yeah.
So you have lower cardiac output, but stable or higher resistance. So not much change in blood pressure at first.
So if the acute effect is weak, why is it such a good long-term antihypertensive?
It's all about gradual adaptation. Over weeks and months, the resistance vessels seem to adapt to that lower cardiac output. The TPR starts to fall. And it's that delayed fall in resistance that's thought to be the main mechanism.
So it's not the immediate effect, but the body slowly resetting its own thermostat.
That's a great way to think about it. And there are other factors too. Decreased renin release from the kidney is a major one, especially in patients with high renin hypertension. There's probably also some central effect, reducing sympathetic outflow from the brain.
Now, we have to talk about the most serious risk of these non-selective beta blockers, the respiratory risk.
This is a life and death issue. Beta-2 receptors in the bronchioles cause them to dilate, to open up.
So if you block them,
you significantly increase bronchial resistance.
Yeah.
Now, in a healthy person, you might not even notice. But in someone with asthma, this can trigger a severe, potentially fatal asthma attack.
So they are an absolute no-go for asthmatics.
An absolute contraindication. Full stop.
Okay, now moving from the lungs to the brain. Propranolol is pretty lipophilic, so it gets into the CNS.
It is. It crosses the blood-brain barrier very easily. Patients don't usually have dramatic central effects, but subtle changes are common. Things like forgetfulness, very vivid dreams, nightmares, sometimes depression.
But it's great for performance anxiety, isn't it?
It's fantastic for that, but not because it's a central anti-anxiety drug. It works by blocking the peripheral symptoms, the tremor, the racing heart, the palpitations. It breaks that physical feedback loop of anxiety.
And then there are the metabolic effects, which are a huge deal for patients with diabetes.
A huge deal. There are two big problems. First, beta receptors help the body raise blood glucose when it's low. So blocking them means it takes longer to recover from insulin-induced hypoglycemia.
And the second problem is even more dangerous.
It is. The sympathetic response to low blood sugar, that rush of adrenaline, is what gives you the warning signs. The tachycardia, the tremor. Beta blockers suppress those warning signs. So you can have masked hypoglycemia that can progress to a coma without you ever feeling it coming.
So after propranolol, the goal became refinement. And that led to these classifications based on a few key properties.
Right. It boils down to three things. Selectivity, something called intrinsic sympathomimetic activity, or ISA, and lipid solubility.
Let's start with the biggest safety leap. Cardioselectivity, the beta-1 selective drugs like metoprolol and atenolol.
The goal here was simple. Hit the heart, which is beta-1, but spare the lungs and blood vessels, which are beta-2.
And the benefits are obvious.
Oh yeah, much lower risk of bronchoconstriction. They're safer in diabetics because they mess less with carbohydrate metabolism. And you get fewer of those peripheral side effects like the cold hands and feet you see with propranolol.
But that selectivity isn't absolute, is it?
No, it's completely dose-dependent. At high enough doses, they lose their selectivity and start hitting beta-2 receptors anyway. And of course, if you actually need that peripheral beta-2 action, say for treating essential tremor, these cardioselective agents just won't work.
Okay, next is this really interesting idea. Intrinsic sympathomimetic activity. ISA, drugs like Pindolol. This means it's a partial agonist.
That's it. A partial agonist is a molecule that activates the receptor, but only a little bit, submaximally.
So what's the point of that?
Think of it this way. When your own sympathetic drive is low, like when you're resting, the ISA provides a little bit of background stimulation. It keeps your heart rate from dropping too low.
But when you're stressed or exercising, and your own adrenaline is surging,
then the drug is occupying the receptor, and it blocks that full maximal effect from your own adrenaline. It puts a ceiling on the response.
So what's the clinical benefit of that?
You get less bradycardia, that slow heart rate at rest, and less depression of heart contractility. So they might be better for older patients or people with borderline cardiac function.
And it also helps with that dangerous rebound phenomenon you get when you stop the drug suddenly.
Significantly less likely.
Right.
Because that low-level agonism prevents the receptors from getting severely upregulated over time.
But there's a downside.
There is. They are considered less suitable for secondary prevention after a heart attack and less effective for migraine. In those cases, you want maximum suppression, and the partial agonism gets in the way.
Okay, last one. Lipid solubility. We can compare propranolol, which is high, with atenolol, which is low.
Propranolol, being highly lipid-soluble, loves fatty tissue. That's why it gets into the brain so easily and causes those CNS side effects.
But I know pharmacokinetically.
It means it gets chewed up by the liver on its first pass-through. A lot of the dose is lost, and it has a shorter half-life.
And atenolol, being the opposite, is hydrophilic.
Right. It doesn't get into the brain as much, so fewer CNS side effects. It's not absorbed as well, but it avoids that first-pass metabolism and is mostly excreted by the kidneys.
So it has a much longer half-life.
Much longer. It's often a once-a-day drug. The choice between them often comes down to weighing the risks of CNS side effects versus the patient's kidney function. So when we use these drugs, the safety protocols and long-term consequences have to be top of mind.
Let's just run through the absolute contraindications again.
Well, beyond bronchial asthma, which is number one, there are the cardiac risks. You can't use them in acute congestive heart failure. The sympathetic system is the only thing keeping that failing heart going, and if you knock that crutch out, you can cause a catastrophe.
And also in patients with electrical problems in the heart.
Right. Pre-existing partial or complete heart block. There's a real risk of causing cardiac arrest.
You also mentioned a specific kind of angina where they're a bad idea.
Variant, or vasospastic angina, that's caused by coronary artery spasms. The beta-2 receptors help dilate the coronary arteries, so if you block them, you leave the alpha receptors, which cause constriction, unopposed.
So you could actually make the spasm worse.
Much worse.
And what about long-term metabolic effects like cholesterol?
The older, non-selective agents were known to raise triglycerides and lower the good HDL cholesterol. It was a concern for long-term coronary artery disease risk. The newer third-generation drugs are much better on that front, but it's still something to monitor.
All right, let's really spend a minute on the rebound phenomenon. This is such a clear example of the body fighting back. Why is it so critical to stop these drugs slowly?
Because the body is always trying to maintain homeostasis. When you chronically block the beta receptors, the cells sense that they're not getting enough stimulation.
So they do something about it.
They build more receptors. It's called upregulation. The heart muscle becomes starved for that sympathetic activity, so it puts more and more locks on its surface, waiting for a key.
And then what happens if you suddenly stop the drug?
Suddenly, all the patient's own catecholamines, their adrenaline and norepinephrine, come flooding back, and they find this huge, hyper-responsive population of upregulated receptors.
It's an explosion of sympathetic activity.
A massive overreaction. And that's the rebound. You can get severe hypertension, a worsening of angina, or even sudden death from a ventricular arrhythmia. This is why you must taper the dose over 1 to 2 weeks. It's mandatory.
Okay, so that journey brings us to the really specialized third-generation agents, the hybrid blockers that can do 2 jobs at once.
Exactly. These are drugs that have both alpha and beta blocking capabilities in a single molecule. Labetalol was the first big one.
Labetalol is a pharmacological cocktail. What exactly is it blocking?
It blocks beta-1, beta-2, and alpha-1 receptors. It even has a little bit of weak beta-2 agonist activity.
And the potency matters here, right?
The ratio is critical. It's about 3 to 5 times more potent at the beta receptors than the alpha receptors. So at a low dose, it's mostly a beta blocker, but as you increase the dose, that alpha-1 vasodilation really kicks in.
So you get the reduction in cardiac output from the beta block, plus a reduction in peripheral resistance from the alpha-1 block.
Correct. And that balanced vasodilation means that, unlike propranolol, labetalol actually maintains or even increases blood flow to the limbs. It's hemodynamically a much smoother drug.
And its main use is for emergencies.
Yes, it's a mainstay for acute hypertensive emergencies. Things like pregnancy-induced hypertension or the blood pressure spike you can get from clonidine withdrawal.
Now, what about carvedilol? This has become a really important drug for chronic heart failure.
Carvedilol also blocks beta-1, beta-2, and alpha-1. But what makes it special are its other properties. It's a powerful antioxidant, scavenging free radicals, and it also has some calcium channel blocking activity.
So it's not just reducing the heart's workload, it's actively protecting the heart muscle tissue.
That's its cardioprotective advantage, and that's why it's so widely used in chronic CHF. It helps interrupt that whole cycle of sympathetic damage and remodeling that makes heart failure get progressively worse.
Okay, so let's just nail down some of these essential clinical uses beyond basic hypertension, starting with a heart attack and MI.
There's a dual role here. First, acutely. If you give it IV within the first few hours, it can limit the size of the heart attack by reducing oxygen demand and preventing dangerous arrhythmias.
And then long-term, after the patient has recovered.
This is where the evidence is just overwhelming. Long-term use of beta blockers after an MI reduces the risk of dying over the next few years by about 20%.
Wow.
They prevent recurrent heart attacks and sudden cardiac death. But again, the drugs with ISA, those partial agonists, you generally avoid for this.
All right, let's tackle that paradox again. How can a drug that's contraindicated in acute heart failure be a cornerstone therapy for chronic heart failure?
It's one of the great stories in modern cardiology. In chronic heart failure, the body's compensation mechanism is to crank up the sympathetic nervous system. So you have this constant deluge of adrenaline hitting the heart.
Which seems like it would help, but it's actually damaging long-term.
It's incredibly damaging. That chronic stimulation accelerates cell death in the heart muscle and promotes this unhealthy structural remodeling of the ventricle. The sympathetic nervous system is actively destroying the failing heart.
So the beta blocker interrupts that process.
Exactly. When you introduce certain beta-1 blockers, metoprolol, bisoprolol, carvedilol, at a very low dose and titrate up slowly, you block that damaging effect. You retard the progression of the disease, improve heart function over time, and most importantly, you prolong life.
But you can only start it once the patient is completely stable.
Completely stable and free of fluid overload. It's a very careful process.
And what about in thyrotoxicosis, an overactive thyroid?
High thyroid levels make the body hypersensitive to the sympathetic system, so beta blockers are perfect for rapidly controlling the symptoms, the palpitations, the tremor, that fixed stare. Plus, drugs like propranolol have a bonus effect. They inhibit the conversion of the less active thyroid hormone T4 into the more active T3.
So they're a bridge to let the other drugs kick in.
An invaluable bridge.
And finally, their use for anxiety and tremor.
For essential tremor, it's a direct treatment. You need the non-selective agents for that beta-2 action on the muscle. For anxiety, they're brilliant for situational or performance anxiety.
Because they block the physical symptoms.
Right. They stop the racing heart, the shaky hands. They short-circuit that feedback loop that turns nerves into a panic attack, all without the sedation you get from a traditional anxiolytic. So to finish up, let's look at a really specific, really successful local application of these drugs. Managing eye pressure in glaucoma.
Yeah, glaucoma is this silent disease, progressive damage to the optic nerve, usually linked to high intraocular pressure, or IOT.
And the whole goal of treatment is just fluid dynamics.
Yeah.
The aqueous humor, the fluid inside the eye, is constantly being made and constantly being drained.
So to lower the pressure, you have to either make less fluid or drain it out faster.
That's it. And adrenergic receptors are key to this. On the ciliary body, the tissue that makes the fluid, you have beta-2 receptors. When you stimulate them, you enhance fluid secretion.
Okay, so beta-2 means more fluid.
Right. But you also have alpha-2 receptors there. And when you stimulate them, you reduce fluid secretion. So that gives us two clear ways to tackle this.
You can either block the beta-2 system or stimulate the alpha-2 system.
Exactly.
So the topical beta blockers were the gold standard for a long time. They just block those beta-2 receptors to reduce fluid formation.
And they were a huge improvement over the older miotic drugs. Miotics would constrict the pupil, which messes with your vision. Beta blockers don't do that.
Timolol is the prototype here. It's non-selective, just like propranolol.
It is. It blocks beta-1 and beta-2, and it gives you a great 20 to 35% reduction in eye pressure. Plus, it has a long residual effect, which is a nice safety net if you miss a dose.
But that non-selectivity means you have that systemic risk again, even from an eye drop.
This is so critical for people to understand. The eye drops do not stay in the eye. They get absorbed through the nasolacrimal duct into the bloodstream.
And that can cause real problems.
It can, and it has. Life-threatening bronchospasm in an asthmatic, severe bradycardia in someone with a heart condition.
So there's a simple physical trick to minimize that risk.
A very simple one. You just apply gentle pressure to the inner corner of the eye for 3 to 5 minutes after you put the drop in. It blocks the duct and stops the drug from getting into your system.
Now, what about the beta-1 selective agent, Betaxol?
Betaxol was made specifically to try and avoid those systemic side effects. It has a much lower risk of pulmonary and cardiac problems, but it's a classic trade-off.
It's less effective.
Significantly less effective than timolol, because the receptors that make the aqueous fluid are mostly beta-2.
So you lose some efficacy to gain safety.
You do. Although Betaxol might have this other neuroprotective effect on the retina that's independent of pressure lowering, which is interesting. But the choice is usually efficacy versus safety.
And the standard of care has actually shifted now, hasn't it?
It has. Prostaglandin analogs are now the preferred first-choice drugs for most patients with open-angle glaucoma.
Why do they take over?
Drugs like latanoprost, they're incredibly effective, often even more so than timolol. But the key is their mechanism. They don't reduce production, they increase uveoscleral outflow. They help drain the fluid out better.
And they're safer systemically?
Almost no risk of systemic cardiac or pulmonary issues. They're once a day, they're well tolerated, they're just a better first choice for most people.
Their side effects are mostly local and, well, cosmetic.
Exactly. They can cause the iris to turn permanently brown, and they cause this dramatic darkening and thickening of the eyelashes. Patients need to know that's going to happen.
And what about the alpha agonists like brimonidine?
They stimulate those alpha-2 receptors to decrease fluid production. Brimonidine is pretty selective for alpha-2, so it's a good long-term option, or as an add-on therapy. Side effects are usually mild, like dry mouth or a bit of sedation.
And finally, the carbonic anhydrase inhibitors, the CAIs.
Like dorzolamide topically, or acetazolamide as a pill. They reduce fluid formation by messing with the bicarbonate ions needed to make the fluid.
But they're not first line.
No. Dorzolamide is an add-on. And the oral drug, acetazolamide, is really only for short-term or emergency use because the systemic side effects are pretty severe.
Okay, so let's just summarize the strategy. For chronic, open-angle glaucoma,
You start with monotherapy, usually a prostaglandin analog. If that's not enough, you add or switch to a topical beta blocker or an alpha-2 agonist. Miotics and oral CAIs are really a last resort.
But angle closure glaucoma is a completely different beast. It's a medical emergency.
It's an emergency. You need immediate, aggressive, multi-pronged therapy to get that pressure down before there's permanent vision loss.
How do you do that?
You start with intravenous osmotic agents like mannitol and intravenous acetazolamide. These pull water out of the eye very rapidly.
And the miotic, pilocarpine, only comes in later.
Only after the pressure has started to fall. If the pressure is sky high, the muscle at axon is paralyzed. Once the pressure is lower, the pilocarpine works. It constricts the pupil and physically pulls the iris away, opening up the drainage angle.
But the real fix is surgical.
The definitive fix is always surgical or laser iridotomy to prevent it from ever happening again.
Wow. This has been an incredibly detailed look at receptor manipulation. We've mapped how just targeting these alpha and beta receptors gives us this incredible control over the sympathetic system.
From heart rate and blood pressure all the way to, urine flow and even the fluid balance in the eye.
The big takeaway, it seems, is the importance of specificity.
That's the whole story. The move from a non-selective drug like propranolol, a blunt instrument, to a highly selective drug like campsilocin for the prostate or nebivolol for the heart. It's not just about marketing.
It's about safety.
It's all about safety. It's about minimizing off-target damage. It's what makes these drugs usable in patients with other conditions, like asthma or diabetes. Selectivity is the difference between a risky tool and a precision instrument.
And it's fascinating that the newest drugs are even moving beyond just blocking things.
They are. Take nebivolol again. It's a highly selective beta-1 blocker, yes. But it also does something else. It activates endothelial nitric oxide synthase.
So it promotes vasodilation through a completely different pathway.
Exactly. The drug isn't just blocking a bad signal. It's actively recruiting a separate beneficial signaling pathway, the NO pathway, to improve blood vessel health.
So it raises this really interesting question for the future.
It does. Can we design all our drugs this way? So that they don't just treat a symptom by blocking a receptor, but they simultaneously leverage another pathway to improve the underlying health of the tissue itself. It's a compelling future where, antagonism meets enhancement.